Diagnostics and endovascular treatment of stroke.
Thank you very much. Good afternoon, ladies and gentlemen, dear colleagues. It's a great honor and pleasure to be part of this remarkable conference here in Egypt, and I want to thank the organizing committee for invitation and opportunity to be a speaker on this conference. Shukran. So we are proud, actually, in Croatia that our department, Neuroradiological and Neurointerventional department, is the only referral center in Croatian Ministry of Health for radiological prevention, diagnostic, therapy, and rehabilitation of head and neck diseases. Also, actually, I have been managing a European Union project on MRI education. We call it Radiological Education Center, worth €4 million. As you already know, mechanical thrombectomy is the newest interventional radiological method which should be performed within 24 hours from symptoms onset. In our hospital, University Hospital Center, Sisters of Mercy, which is the oldest one and second biggest hospital, we performed since 2014 more than 400 mechanical thrombectomies. At the beginning, 2013, we performed only 13 cases, but we put a lot of effort to organize stroke center, and now it's going on. It's indicated for patients with acute ischemic stroke due to a large artery occlusion in the anterior and also posterior circulation. The main question is, who is candidate for mechanical thrombectomy? We know that some of clinicians are most responsible for this decision. First of all, for clinical diagnosis, neurologist, and second one, very important, is neuroradiologist and interventional radiologist. So we actually now organize in our hospital stroke center, which is the second biggest stroke center in our country. But let's go to talk about imaging methods, what we have for these cases. So first imaging method is, of course, non-enhanced brain CT. Second one is CT angiography. We could perform also in some cases CT perfusion. In some cases, MRI is very useful, especially DVI. Then, of course, in that cases, we can perform MRI angiography and MRI perfusion. Let's start with non-enhanced brain CT. The main goal is actually exclude some other conditions which can mimic actually stroke. For example, as a tumor or intracerebral hemorrhage. We are also looking for early features of infarction and, of course, look what is the situation with leptomeningeal collaterals. For the beginning, as you already know, hyperdense MCA sign, we are looking left or right side. Of course, we have some clinical information always, and then second thing, we are looking for other early infarction signs. At the beginning, for 6 hours, we know that sensitivity of CT is quite low. It's about 60% for changes, but very often we see very discrete changes. And we talk now about aspect score, which can help us to decide who are best candidates for mechanical thrombectomy. Aspect score was developed to offer the reliability and utility of a standard CT exam with a reproducible grading system to assess early ischemic changes on pre-treatment CT studies in patients with acute ischemia. And this, not only CT, we can use also MRI, especially DVI sequences. The aspects method divides the middle cerebral artery territory into 10 regions of interest. On the two levels, first level is on the level of the hypothalamic and basal ganglia, and the second level is just rostral to the basal ganglia. To describe precisely, subcortical structures are allotted 3 points. So we have nuclei coded, then we have 1 point, it's lentiform nuclei and capsula interna. And then we divide MCA. Cortex has 7 points, insular cortex, anterior, lateral, and posterior MCA cortex, and then rostral M4, M5, and M6 regions. So who are best candidates? Of course, patients with a high aspect score between 8 and 10, but we perform for the patients who has 6 or more. And if you look at the left side, we don't see any demarcation, so its aspect score is 10. But on the right side, we have diffuse ischemic changes, so this aspect is 10 and it's not a candidate. When we analyze, it's good to change window, so we use 35 and 35, it's better. And if you look on the left imaging and on the right, you have on the right, easily can see temporal region, it's a slight hypodense. At the same time, after non-enhanced CT, we perform always, of course, CT angiography. And we use some protocol which is standard, and always perform CTA reconstructions. First of all, a maximum intensity projection, but also some other multiplanar reconstructions. What can CT angiography help? So first of all, we will find localization and length on strombs and or embolus. Then very important for the planning of endovascular approach, extracranial vessel status. Then on CT easily to distinguish wall calcification. And very important, it's to see what is the situation with collaterals. So on the left you can see very good status of leptomeningeal collaterals, and on the right very poor. For this status we use CT and CT contrast after 2 minutes. So we analyze both imaging. So in grade 0, no collaterals. Then we have 2 for slow but complete collaterals, detectable only on delayed contrast enhanced CT without defects. And we have number 3 is a fast and complete collaterals detectable on both CTA and delayed CT. Contrast enhanced CT. So of course these 2 and 3 are best candidate for mechanical thrombectomy. And also very important, in some patients after 6 hours it's a CT perfusion, where we can identify who are patients with small core and a large penumbra, and they are also very good candidates for the mechanical thrombectomy. We analyze 3 parameters: mean transit time and time to peak, then more important cerebral blood flow and cerebral blood volume. And as you know, main difference between core and penumbra, it's actually cerebral blood volume. For core it's markedly decreased, and for penumbra it's near normal or increased. And this is due to autoregulation, vasodilatation. But also flow in core is markedly decreased, and in penumbra it's moderately reduced. In some cases, quite rare, but we use MRI. It's useful for wake-up stroke, or in addition to MSCT in patients with posterior circulation symptoms. You know that it's less sensitive for acute hemorrhage, but very often we have to use whatever we have. So if we don't recognize on CT, if someone is candidate, we can perform MRI as well. As you already are familiar with, cytotoxic edema and restriction of diffusion, it's easy to distinguish very early on DVI and ADC. Very rare in our department we perform MRI perfusion and of course together with MRI 3D TOF. So for the most cases we use CT and CT angiography. To detect penumbra, there is several possibilities in CT perfusion, CBV and MTT mismatch, in MR perfusion, DVI and MTT mismatch, and clinically DVI and NIHSS score mismatch. And I will show you a few examples. This is a male, 61-year-old. We perform CT, and you can see on the right side, it's hyperdense media. Then on the CT angiography, it means aspect score was 10 because we didn't see any demarcation. On the CT angiography, we actually find occlusion of M1 segment on the right side. Mechanical thrombectomy was indicated and performed in general anesthesia via right transfemoral approach and by setting balloon on the leading catheter in the right communis carotid artery, and stent retriever was also introduced in the upper empty branch and aspiration catheter in distal part of ICA, and finally we got TC score 3 after only one maneuver. And we perform, of course, the control CT and no any demarcation, so it was very successful procedure. Second case was male, 60 years old. Brain CT was normal, so aspect score was again 10. Of course, this kind of patients are very good for the mechanical thrombectomy, and if you perform that very early, we can expect very good outcome. On CTA, we can see occlusion of left carotid artery, internal carotid artery. So we perform DCA, and it was after mechanical thrombectomy. We've got successful recanalization, and it was with the balloon guide catheter and stent retriever. Also, we perform mechanical thrombectomy for posterior circulation. In that case was a younger woman, female, 51 years old, and we perform CTA, and occlusion of basilar artery is easily to realized. So on DCA, the procedure is performed in general anesthesia, of course, with blood pressure monitoring and systemic heparinization, and it's also visible that it's occlusion of the basilar artery. And after mechanical thrombectomy, after stent retriever placement in basilar artery, the waiting time was 2 minutes for stent expansion, and under fluoroscopy guidance thromb aspiration has been performed, and we've got good recanalization. We perform also a control CT, and if you look carefully, we have small hyperdense medullary area, so it was not hemorrhage, it was just contrast media extravasation. because we realized on later CTs. And this is one younger male. It was occlusion of M2 segment, so we performed again non-enhanced CT and CT angiography. Aspect was 9. And we performed MR perfusion, CT perfusion, and he had right hand plasia, and we of course do DSA and start with mechanical thrombectomy, because core was quite large, but penumbra was quite small, and he was young. And after recanalization, even during the procedure, patients start to move with hands, so finally he had slight disability, what was very important for this so young person. So we performed also a control CT in this patient. We have a demarcation of the area where was ischemia, but finally actually quite good outcome. And after the endovascular procedure, we perform within 24 hours or earlier in some cases controlled CT. What we can see, of course, we control our endovascular procedure. We can detect some potential hemorrhage, checking ischemia, extent, etc. This is one example where we've got 24 hours after dilatation using balloon catheter of right internal carotid artery and one M1 segment of right MCA with dissemination in both M2 segments. But you can see that CT shows acceptable results. We have only frontal, on the right side, frontal some hypodensity and demarcation of ischemia. That case was actually with poor outcome. We had clinical deterioration, and first control after 24 hours was quite huge ischemia, and after 4 days we realized even worse. And bigger demarcation of ischemia with herniation, and unfortunately it was a bad outcome. Sometimes we have some complications, of course, unfortunately, as hematoma. This is the first day, and after 8 days you could see this very, I mean, it's an older person, 81-year-old, with poor collaterals. What was actually the main reason? And finally, we were actually not successful with our procedure. And this is the interesting example, 28-year-old male patients, and if you see, we have some hyperdense area in basal ganglia. And second control CT after 5 hours. So the first one was after 2 hours, and second one after 5 hours. We can see that it's less visible, this hyperdensity, and we conclude that actually it was contrast extravasation. What are benefits of early treatment? 5 multicenter open-label randomized controlled trials demonstrate that early intraarterial treatment with second-generation mechanical thrombectomy devices is safe and effective for reducing disability, and it's superior to standard treatment with intravenous thrombolysis alone for ischemic stroke caused by a large artery occlusion in proximally anterior circulation. And these are the one-step trial, the MRI clean trial, where they recommend when we can perform mechanical thrombectomy. So we have still time. So when we have aspect score 6 or more, of course, by using CT ruling out intracranial hemorrhage, and in cases we have intracranial arterial occlusion. What about after 6 hours? We perform also because we realized that it's not only this small window what we can use to help to our patients. So this is a diffuse 3 trial. So they recommend mechanical thrombectomy within 6 to 16 hours. If we have arterial occlusion of the cervical or intracranial internal carotid artery or the M1 segment of MCA. Then also a target mismatch profile, so on CT perfusion or MRI defined as an ischemic core volume, less than 70 milliliters. Mismatch ratio more than 1.8, it means the volume of the perfusion lesion divided by the volume of the ischemic core, and mismatch volume of more than 15 milliliters. And Dawn trial, they recommend within 6 to 24 hours. So when we have baseline infarct involving less than 1/3 of the territory of the MCA, intracranial arterial occlusion of internal carotid artery or the M1 segment of MCA, and clinical core mismatch according to age. Actually, I show our experience and how we try to follow and cure stroke in our center, but there is no consensus about imaging method for mechanical thrombectomy candidates, so we usually use non-enhanced CT and CT angiography. Honestly, actually, even in cases who come after 6 hours, we don't use a lot CT perfusion because of time. Some of colleagues are not so familiar and it takes time, but these two methods, CT and CTA, it's good for procedure planning, checking collateral status, vessel occlusion, and stenosis visualization, and usually they always have expert meeting using telephone and decide together with imaging and clinical informations and decide who is a candidate or not. So this is a small country comparing with Egypt, and our experience in Croatia and some other European countries show that organizing a national network for acute ischemic stroke management is needed. Nowadays, mechanical thrombectomy is performed in 3 centers in Croatia. This is our team, so we are quite young. Some of us, we do diagnostic neuroradiologists, and some of us, actually guys, they do interventional part. So thank you very much for your attention, and don't hesitate to ask if you have any questions. Thank you very much.
Thank you very much, Professor Dijana, for your interesting talk and to sharing your experience for mechanical thrombectomy with our colleagues here. I wish you visit some of our centers here also, because we have very good teams here working in that field. So you're most welcome. Thank you very much for your talk. Any questions, please? 2 questions allowed. Okay, so thank you very much. It was